Continue. So first of all, again, thank you very much for the opportunity to present at this meeting. I will do this on behalf of the HTA development platform, which I'll explain in more detail in a minute. First of all, I would like to say, actually looking at the topic of today, so in general, health technology assessment is already, I think, in the press, in the media already for decades, for almost more than 40 years, that we actually have the same discussion, whether we can put a price on the value of a human life. Normally we say, for example, that only when you have a concrete HTA agency, this is the way forward to put a price on human life. But if you see, for example, already implicitly in many policies, we see that this already happens. This is, for example, one media press of the New York Times. I think it's really worthwhile. We'll share the slides after the meeting to read the entire article, because it's really interesting to see how we already actually place a value in human life without having even an HTA agency. The other thing which I would like to declare first before going into the content is that there's even, let's say, a trend nowadays over the last decade that we think that we are individually also becoming more and more responsible for our health behavior, and as such also our health status, and that we believe that maybe healthcare should not only be, should maybe be less accessible for those who have less healthy behavior. One of the concrete examples is nowadays in the United Kingdom, and I would like to share a video about this, is to see actually whether we should think as a country, for example, in the Netherlands or in Egypt, that people that smoke, for example, should have less access to healthcare than people that don't smoke. Same counts for obese. And I will show in a minute a short video about this. And happy to hear your thoughts on this theme as well. Can you all see this?
Yes, oh, please. Yeah.
Perfect.
Here, some NHS patients are given an ultimatum. Under new rules, some smokers will only be referred for certain operations if they quit smoking. Those who are obese may be restricted from having non-urgent surgery until they lose weight.
Clinical commissioning groups, and these are the GP-led organisations that plan local care, they're facing tough decisions this year about how to balance their budgets. The Hertfordshire case is not a one-off. The majority of CCGs are having to consider different ways to restrict access to patient care in order to balance their budgets. So I think we can expect to see more and more of these cases of CCGs having to take really tough decisions about how to meet their financial targets.
The NHS is under huge financial pressure because demand for care is going up much faster than funding. It means, like Hertfordshire, many areas are taking more stringent decisions. But is that fair?
I don't think it should be a blank, we can't treat you because you smoke. I think they should perhaps say you need this, but, we want to see that you're stopping smoking in the meantime.
Never smoked in my life, and I do feel that it should be considered, absolutely, yes.
I believe that if you paid into National Health all your life, then you should get treatment.
The Royal College of Surgeons has become increasingly concerned about the rationing of surgery in the NHS. It commissioned a report which last year showed that now nearly a third of clinical commissioning groups in England and One Health Board in Wales now have policies which require patients either to lose weight or stop smoking before they can be referred for routine surgery. It fears some patients are becoming soft targets for NHS savings. The Royal College of GPs is also worried, saying trying to force patients to change won't always work.
Everybody knows that smoking is bad for us, that drinking excessively is bad for us. We also all know that eating too much red meat is bad for us, and that living sedentary lifestyles. But it doesn't mean that we all live by those rules. And so there's a difference between encouraging people to make the right choices, making it easy to live good, healthy lifestyles, but then actually enforcing rules upon them that they weren't expecting, and in a situation where they haven't got much control. That is tough.
Hertfordshire Clinical Commissioning Group says its policies are not about saving money, but are to improve patient safety during non-urgent surgery. But some argue that these strategies are destroying the fundamental principles of our NHS.
So I was quite curious actually what your opinion is on this. Is this, for example, a way of policy making which we think that really encourage people to actually have a healthier behavior? Or do we really think from a policy perspective that this is a kind of soft way, soft targets towards cost saving? I'm quite curious to hear your opinion about this. So for example, is this something that also already happens in Egypt? That, for example, there is the decision making with respect to policies on healthcare, accessibility of healthcare, depending on someone's healthy behavior or not?
Feel free to unmute yourself if you want to participate in the conversation with Dr. Raoul.
So maybe you know more about this, Noura, whether this is the case. Is this something that happens already in Egypt?
In my limited experience, I don't think there's these kinds of rule in Egypt. I don't think there are these like strict rules to implement like healthy lives. There are campaigns and stuff like this, but not strict rules or to like implement to start losing weight or stopping smoking or something like this. Just like campaigns, no strict rules.
Yeah, I think we see more or less the same in the Netherlands. Already a trend towards maybe that people should, for example, that quality of care is related to reimbursement, but nonetheless, we strongly believe that, let's say, in the coming decades, this might become more and more included in policy making. That's why I also found it really interesting to share it with you. Okay, let's continue. First about our HTA development platform, the mission that we have. We initiated in the summer of 2020 and already more than 4 countries are now aligned. What we mainly develop, actually the pillars of the foundation of our activities, is that we focus on developing and monitoring an efficient HTA system, mastering the necessary skills and knowledge exchange. Most importantly, what we would like to do is really together with the countries involved, try to further develop their HTA system from what is already there and to see actually what we can contribute to do their ideas and also the goals of the government of these countries. That's also the way we started in collaboration together with Gian with respect to the Egyptian system. What we provide a country-specific implementation plans, including what's also an opportunity, especially after COVID, also on the ground, an implementation manager. We provide financial and project-specific recommendations. So we, for example, strive together for funding for activities, a country-specific educational program to master necessary skills. We see that there are in many countries there's already kind of basis in health economics knowledge and also in health technology assessment. We provide educational programs to further develop this. Also, for example, programs to develop teaching skills in the country. So that's not only that we provide the information, but also develop on the floor more knowledge in how to teach it to others. Stimulation of the collaboration between HTA agencies, their Ministry of Health, and like-minded countries' HTA agencies. So for example, we see in many countries there is still no eSport chapter or something else, an initiative that stimulates really this, let's say, a threesome between a ministry, such an, for example, chapter and agencies or offices that are already running. And we aim to have a focused offline online community of partnered countries. If we have more countries aligned, we would also like that these countries can learn from each other. For example, that we see that countries are in a different stage of development and maybe they can help each other out. Same counts for us. We can learn a lot from these countries because they have, I think, way larger challenges with respect to healthcare than we have, for example, in the Netherlands. So I think we can even also learn a lot from the countries that align to the platform. So that's how we would like to contribute. One of the things that I missed out to say is really interrupt me if you have any question or would like to know something, or I think Noura can unmute you, or you can also unmute yourself. Please do so, and please again feel free to interrupt me if you want to know anything about our platform or something I'm saying or presenting. Who am I? My name is Roel Frerichs. I'm currently an assistant professor at the University of Groningen, 1 day a week. 4 days a week, I'm running the management team of a global health economics consultancy called Ask Academics. We are working mostly in Europe, but also in, we've worked a lot in Africa, United States, and also in Southeast Asia. I'm also a board member of the Dutch Flemish Health Economics Association in the Benelux, sitting board member as well from that perspective in the International Health Economics Association worldwide. And for today, I'm the vice chairman of this platform. So that's mainly the focus point of today. Shortly about my work, I've been running around already a little bit in short academic career so far with respect to publications in health technology assessment. My own private, let's say my personal interest in academia is mostly on method development in health technology assessment. So I try to look beyond the methods that are already there and do something different with respect to cost effectiveness analyses. Same wise, I'm also involved with a lot of research now in COVID-19. And mostly focusing on the relationship between socioeconomic status and COVID-19. We see in the Netherlands, for example, that people that already are from a poor background, for example, or a non-Western background are targeted even heavier with COVID-19 than people from, let's say, a native Dutch background or a richer background. And it's something I think is more or less already quite ignored again. You see it often with new diseases and as well with, for example, things like pandemic. First, they focus on, let's say, the average people, on all the society as a whole. And then after a few years, we see that especially some subgroups, like, for example, people from a poor background are actually the people that are have the highest burden of disease. This is something why we already focus on it in the early stage. If you would like to have one of the papers or something else, please feel free to contact me afterwards. I think Jan or Noah can share my contact information. And feel free to contact me if you would like to have a paper or share something about this. Okay, cool. Yeah, of course I will. So please send me a text on LinkedIn or send me an email and I can share all the documents. The agenda for today for the workshop or short presentation is the history of HTA. I will shortly touch that again. Then the HTA system of the Netherlands. For this, I have invited a guest speaker who has way more knowledge about this than myself. We've made some slides to summarize it, so I'll present these slides after him, but I think it will look terrible after his presentation because he knows way more than I do. Then I will shortly present my view on the HTA system of Egypt. Also, maybe interesting to see whether I miss out a few things, because of course, mostly is done in meetings with Guillaume, but mostly is based on the things that I can find online. And based on this, I compared both systems and came up with some opportunities for further collaborations with the HTA office, and also to see where are the gaps and how can we maybe close them. I've put on some statements which you would like to have your opinion on, so that we can also have a little bit interactive discussion and not us talking the whole 2 hours and you listening. So that's the agenda for today. So HTA, yeah, HTA started in the US officially already a lot of years ago by the Office of Technology Assessment, OTA, followed by the formation of the Swedish Council of Technology Assessment and Healthcare, the SBU, in 1980. In 2018, the HTA office in Egypt was originally founded. In the Netherlands already, I think, 20 years earlier, but I think Mohammed knows it better in a minute. And the first article covering HTA in Egypt was published in 2011 already. So, and you also see in Egypt already for more than a decade, they focus a lot on HTA. And I know, for example, also with the meetings I had with Guillaume, is that you see that that in Egypt there are, let's say, they have high target goals from the policy perspective, especially with respect to, for example, out-of-pocket expenses, accessibility to care, and there is a kind of interesting connection towards HTA. You see that these goals that the policymakers have actually are quite aligned with also the development goals, for example, from the HTA office with respect to the HTA system in Egypt. So I think you already see there that HTA is really an important aspect of a country with respect to their healthcare. Healthcare in the Netherlands, shortly, I think, yeah, we are with almost 18 million inhabitants. Yeah, our GDP is around 907 billion, estimated in 2019. Healthcare costs are rising rapidly. So, for example, it was a couple of years ago below 3%, and it's almost growing with, I think, on average, a percentage point a year. So it currently is 10% of our GDP. We also see that other healthcare aspects are really growing in this percentage points. So for example, we see the mental health care is growing quite rapidly, and also rare diseases. Our out-of-pocket expenditure is relatively quite low, so it's 10.8%. This is relatively to many non-Western countries, I think, quite low. And also the fact that we have a very high estimated insurance coverage percentage points in our country. We have, I think, only below 3% of the people who are not insured. So they all have accessibility to care. But also there you see mostly that, for example, in this 3 to 5% of people that are not insured, you still see a kind of trend in the sense that there are mostly people from a poor background, people from a non-Western background. And again, you see that the burden of this aspect of healthcare is mostly targeted in the same groups. And what I found interesting to hear today, if this is also the case, for example, in Egypt, that you see that the burden of disease is mostly allocated to people that already are, let's say, in a place with a lower perspective. So for example, with a poor background, or one per parent family, or even non-parent family. So that are, I think, interesting discussion points, both in practice, but also from an academic perspective. But without further ado, I would like to introduce, to explain a little bit more about the Dutch HTA system. I would like to introduce to you Mohammed El Alili, also a doctor from July, did his PhD in the Netherlands, currently pharmacoeconomic advisor of the Dutch HTA agency, called in the Netherlands the Zorginstituut Nederland, and also a postdoctoral researcher in HTA in Amsterdam. So I will stop sharing my slides and give the floor to Mohammed to tell you more about the Dutch HTA system.
Yes, I can unmute myself. So hi all, thank you, Roel, for giving me the floor. Let me check. I need to share my screen. Yes. Can someone tell me if you see my presentation screen?
Yes, Dr. Mohammed, you can see.
Yes, okay, thank you very much. This is full screen, perfect. Well, thank you, Roel, for the introduction, and thank you for inviting me today to give a talk about the Dutch reimbursement system, but also thank you the Egyptian ISPOR chapter for organizing this teaching activity. Well, my name is Mohammed, and I have been working for a while as a pharmacoeconomic advisor now. And I'm also finishing my PhD at this moment in the field of methodology of economic evaluations, specifically the statistical analysis of costs and effects data in so-called trial-based economic evaluations. So both jobs actually are very relevant to each other, because what I actually do on a daily basis at the National Healthcare Institute is to critically evaluate the methodology of submitted HTA or pharmacoeconomic analysis that we get, in which obviously the effectiveness, cost effectiveness of a certain new intervention or drug is claimed. But before I'll start my presentation, I want to kick off with a relatively rhetorical question. Whoever did buy something that didn't work? And you don't have to answer this at this moment because it's relatively difficult to do this in an online environment, but I can answer this question for you, I think, because everyone in their life has sometime bought something that doesn't work. And this is a very nice example, an app machine that will give you the apps of Arnold Schwarzenegger, or Mr. Olympia, Big Ramy himself from Egypt, within 6 days. And we all know it is too good to be true. But now imagine a situation where you will buy this product as a gift or whatever for a friend or a relative, and then you pay for it. This is a little bit silly, right? You're buying something that doesn't work. You know it doesn't work for someone else, and you're giving it to that person. Well, that disappointment actually is trying to be avoided by the National Health Care Institute in the execution of healthcare. So if we translate this example to healthcare, it means we don't want to pay for something that doesn't work. Paying for something that doesn't work is just a waste of scarce financial resources that could have been spent otherwise to maximize the health benefit of the population. And I haven't said it before, but if you have any question, type them in the chat, or please interrupt me and ask a question. So I hope at least after this you'll have a little bit of an understanding of the Dutch system, and you can place the Egyptian system into context and understand the differences between the two systems. So as the slogan of the National Healthcare Institute says, in order to avoid this disappointment in buying or reimbursing treatments that don't work, we as the National Healthcare Institute focus on making sure that everyone in the Netherlands receives good care. And that means that we don't want to pay more or less, but only what is necessary. In other words, we want to pay for something that works, that benefits the whole society as a whole. And as Roel briefly discussed before, in the Netherlands, we have a health insurance system. Only 3% of the people are actually not insured, which is a very nice figure, actually. And how does this work? Well, every citizen in the Netherlands is entitled to pay a premium fee. And this system, this health insurance system, is based on solidarity. Everyone pays a little bit, but the care is for everyone. So it doesn't matter whether you're older or younger, you're in worse health or better health, you're poor or you're rich. There is the basic healthcare, the important healthcare is being offered to you without paying it out of pocket. And in order to facilitate this and to actually guarantee the solidarity, we need to allocate the money that comes from all these citizens as efficiently as possible so that we can benefit everyone as much as possible. But before a certain treatment or medication or intervention enters this health insurance package, there are a number of criteria in the Netherlands that we use, which are listed here. We have effectiveness, necessity, cost effectiveness, and feasibility. The first one is very obvious. If something is not effective, we're not even going to consider adding it to the health insurance package and making it available for our population. So in a sense, we can see this as a knockout criterion. Something is not effective, so we're not going to even look at the further steps, the further criteria. The second one is necessity, which refers to the burden of disease, the number of people that have the disease. Are they in need of a new treatment with less side effects? Is there no other treatment option except for this new treatment that is coming in the future, and so on and so forth. The third one, cost effectiveness, which actually is my field of expertise, is cost effectiveness, in which there is a central question: whether the additional effects, the claimed effects of a certain intervention, treatment, or drug are actually worth it to invest in it compared to what we already have in our system. And last but not least, feasibility. We can reimburse this intervention or drug, but if physicians or the uptake is not high, or physicians don't want to prescribe this medication, or hospitals are not going to adopt this new treatment, it doesn't matter reimbursing the treatment and putting it in the health insurance package. So this is very briefly what the package criteria are. And if we illustrate it graphically, we always start with effectiveness. The knockout criterion, remember, as I said, if something is not effective, it is not going to be reimbursed. Is it effective, we go to the next step. And the next step here is the combination of the burden of disease and the cost effectiveness. And burden of disease is a number that we in the Netherlands express as a number between 0 and 1, with a larger number referring to a high disease burden, so a severe disease, whereas a low burden of disease or disease is a disease with less severity. And based on that, we actually determine the willingness to pay. But I will tell you a little bit later on how we do that. After that, we look at the cost effectiveness. Does it fall below or above a certain threshold or ceiling ratio or willingness to pay value? And then we can go two ways. So we can either reimburse it or not reimburse it. And it's not specifically, it not fully depends on whether something falls above or below the threshold, whether something is cost effective, yes or no. There might be substantial reasons why still to reimburse an intervention, even though it's not cost effective, and vice versa. A nice example could be, in case it is cost effective, but still not to reimburse it, is that the treatment is so cheap that the patients actually can bear the costs themselves. It doesn't matter because it's maybe only €5 per month for a patient. That's not a lot. On the other hand, if something is not cost effective, there are multiple ways we can go in order to still reimburse the medication, especially if there is a small group of patients which are really in need of this new innovative treatment, because the older one is very burdensome, it results in large side effects, and the new one is a little bit more promising, but still it is not cost effective, too expensive. In that way, we can go different directions, ranging from negotiating prices with the manufacturer all the way to co-payments and making different arrangements regarding the uncertainty around this cost effectiveness. So remember, cost effectiveness is not set in stone. I will focus today more on the cost effectiveness side, since that's my area of expertise and since we're all HTA experts. Although HTA consists of much more than only cost effectiveness and pharmacoeconomic analysis, because in the Netherlands, our HTA submissions consist of 3 reports. So we have an effectiveness report, we have a budget impact analysis, and we have a pharmacoeconomic analysis. And the latter, the 2 last ones, so the budget impact analysis and the pharmacoeconomic report, those ones are part of the pharmacoeconomic part of the HTA submission, and the other one is so the pharmacotherapeutic report, where the effectiveness is claimed, that is assessed or appraised by our other colleagues, which typically are medical doctors, epidemiologists, health scientists, and so on and so forth. Whereas the pharmacoeconomic part is, oh, I'm sorry, I think someone ring the bell, but leave it. Where was I? Yeah, so we have these 2 pharmacoeconomic reports, budget impact analysis and the budget impact analysis and the pharmacoeconomic report. I'm sorry, I'm going to open very quickly. I'll be back in a sec. Sorry for the inconvenience. Where was I? I was talking about the HTA report. So we have 3, very briefly, effectiveness, and we have 2 pharmacoeconomic parts, a budget impact analysis and a pharmacoeconomic analysis, which is typically a model or a trial-based economic evaluations. And when we assess these economic evaluations, we look at 4 points. We look at whether the methodology that they used, the pharmaceutical companies, was sound, was good, and it didn't result in any biased outcomes or possible bias. Second, we also look at the ICER in relation to the reference value. And I will explain a little bit further on why I call it a reference value rather than a ceiling ratio or a threshold. The third thing we look at is whether the uncertainty is acceptable around the point estimate of the ICER. So that is typically illustrated in cost effectiveness planes and cost effectiveness acceptability curves. And last but not least, is more research useful, and does it help to decrease the uncertainty around the ICER? And within this whole process, we're actually supported, advised, guided by the Scientific Advisory Board, consisting of the various experts in the field, ranging from medical doctors, psychologists, professor in health economics, statisticians, that actually double check the work we do at the National Healthcare Institute. So in the Netherlands, when we talk about methodology of economic evaluations, yes?
I think there was a question on the chat.
Oh, I haven't seen it, I'm sorry.
The question is from Mohammed Rafat. Is the cost effective will be predefined prior to the evaluation?
Let me check. Can you repeat the question?
Is the cost effectiveness predefined prior to the evaluation?
No. Well, the cost effectiveness analysis is actually performed and we get presented ICERs, if I understand the question correctly. But I'm not sure whether you're referring to the reference value or whether you're referring to the outcome of the cost effectiveness analysis. If you're referring...
Sorry for interruption. Can I explain more?
Yes, obviously, yes, thank you. Go ahead.
My question is related to different markets. For example, in Egyptian market, is the HTA will define the cost effectiveness endpoint that they want to be reach out, different from the Saudi market, for example, or other different market, or the same comparison must be done with the same methodology. As we know, the outcome, it depends on a lot of parameters. Yani, one of them is the establishment of the healthcare system itself in the country.
Yes, I think I understood the question. If I can repeat, you're asking whether cost effectiveness analysis should be adopted according to the country specifications.
Yep. Yes.
Okay. Yes, that's typically the case. And actually, this slide that I have here will explain a little bit more further. In the Netherlands, for instance, we adopt a societal perspective, which is in contrast to the UK, for instance, where the healthcare perspective is typically used. So when pharmaceutical companies want to submit their HTA submissions in the Netherlands, they need to adapt their UK model to the Dutch situation, which means that they have to include costs that are relevant from a societal perspective, such as, for instance, lost productivity costs, which are actually all summarized in the Dutch guideline, which is here. This Dutch guideline for economic evaluation in healthcare. I have to say I'm not familiar with the guidelines in Egypt and Saudi Arabia, but I assume there might be some differences in what you expect from the pharmaceutical companies to submit to you or to the Egyptian HTA agency. So for the Netherlands, we have, for instance, also we require pharmaceutical companies to include the EQ5D5 level with Dutch tariffs, a specific discounting rate, and obviously lifetime horizon. And these are just a few examples that we have in our guideline. And I hope this answers your question, Mohammed.
Yes, clear. Thank you, Mohammed.
So that was the guideline. And typically, we require pharmaceutical companies to adhere to this guideline. And if they don't adhere, they should have like an evidence-based reason why not so. So for instance, if they exclude lost productivity costs, they should have a valid reason. For instance, their population is very old, and these people don't work anymore. Those kind of examples. Here, I have a number of examples of methodological issues we look at when we appraise these economic evaluations. The majority of all economic evaluations we receive are model-based economic evaluations. Let's say 80 to 90% of all economic evaluations. And there are a number of issues relevant to each of the approaches in economic evaluations. For instance, missing data. Typically, trial data is used to estimate input parameters. If you ignore the missing data using biased methods, for instance, list-wise deletion or complete case analysis, in case data is not missing completely at random, or there is a large amount of missing data, it might result in biased input parameters, and as a result, biased outcomes of your model. Next, we also look at survival extrapolations. We don't have our own technical appendix. We always refer to the technical appendix of NICE in the UK. And we ask pharmaceutical companies to give us all the parametric distributions and to justify their choices. And we actually critically evaluate and check whether these extrapolations really fit the data and are externally validated with clinical experts. Last, PSA, for instance, did they use enough simulations, the correct distributions for the different parameters, and so on and so forth. For trial-based economic evaluation, missing data, for instance, is also an issue, although here we empirically estimate costs and effects. And if we ignore them, the costs and effects might be biased, ICER as well. And in the guideline, for instance, we recommend to use multiple imputation or maximum likelihood based methods, which are more advanced methods and are shown to be more reliable than naive methods such as mean imputation or listwise deletion. And an example could also be skewed cost data. It's not normally distributed. Using standard parametric methods might result in unvalid uncertainty around the point estimates. So these types of little things we actually double check, and sometimes you'll be surprised by the amount of mistakes that are made. I'm not telling all pharmaceutical companies do that, but sometimes very simple methodology is used, which is in some cases not the most optimal way and can result in very different results. I will show you that a little bit later on. I don't see the chat, so if someone also has a question, just interrupt me, okay?
So far, so good. So it's still
Good.
empty.
Perfect. Then we go to the next point, and that is the relationship between the ICER and the reference value. In the Netherlands, we use one approach in order to determine the burden of disease. And according to that burden of disease, we have a reference value. In the Netherlands, we use the proportional shortfall method. The formula of this method is in the next slide, but the idea behind it is that it's most righteous if we are willing to pay more for people who are in worse health. In this case, we favor older people. The other two approaches have been discussed in Dutch society, but proportional shortfall method came out as the most optimal one. So if we estimate the burden of disease, which is done according to this formula, according to the proportional shortfall method, we actually find a proportion, and this proportion falls between 0 and 1, with a higher number referring to a more severe disease or a worse state. And for each of these ranges, we have determined reference values. And we call them reference values because cost effectiveness is not set in stone. There is no threshold. It is a reference value that we have a look at. And based from that reference value, we look what the further course of action should be. So it is not a hard cutoff value. And in my opinion, if you say threshold or maximum or whatever, then it feels like it is a threshold. So that's also the idea, and that's why we call it a reference value. We have determined 3 reference values for each of the 3 ranges, and these are actually based on preferences in the Dutch society. The first one, the 20,000 euros per QALY, is based on the reference value of the Dutch vaccination program. That's a very simple one. The 2 other ones are actually determined by asking Dutch citizens. So if an average Dutch citizen is asked, what is the maximum amount you want to pay for someone else's health? They came up with a number of 53,000 euros per QALY, and here it is rounded down to 50,000 euros per QALY. Whereas if it concerns his or her own health or health of a relative, this reference value increases to 83,000 euros per QALY. And that is here rounded down to 80,000 euros per QALY. So these are the reference value that we look at, which is also in contrast to the NICE situation where they use 20,000 to 30,000 pounds per QALY, and it is not really based on the burden of disease. Although I think there are some developments going on in order to have a look on how to include the burden of disease and increase the reference values. The last two steps are whether the uncertainty around the ICER is acceptable, typically illustrated in CE planes and cost effectiveness planes, and whether we can decrease this uncertainty and is it useful to increase this increase research. I have an example here of a cost effectiveness analysis that we have performed a while ago. A very nice intervention. It's called Namaste Care Family Program, where this intervention is targeted at elderly patients with advanced Alzheimer's. And we all know Alzheimer's and dementia. These patients, unfortunately, are very difficult to handle. They can go back to their youth. They can become aggressive, depressive, and so on and so forth. And the idea of this intervention was to make them more calm. So they had a Namaste room in a nursing home where they were playing very calm music. The room had a nice scent. They were given foot and hand massages. They were given nutritious food, all to try to improve their well-being and to make them a little bit more calm. In the main analysis, we have found that it resulted in a cost saving and a very, very small increase in quality of life as measured by the quality adjusted life year. Both are non-significant, resulting in an ICER of minus 315,000 euros per QALY, which means that for each QALY gained, we save 300,000 euros. The idea why I'm showing you this example is that the methodology can really have an impact on results, because when we ignore the missing data and we use list-wide deletion or complete case analysis, as it's also called, we see that the incremental costs and the incremental effects, their magnitude changes. It is still the same negative ICER, but we have a positive cost difference and a negative effect difference. Actually, this means that the intervention is dominated. Usual care is better than the intervention. This might not be the most perfect or the most optimal situation, because you would expect a pharmaceutical company to send in something that is favorable. So in this case, they would use the most advanced method. But in some cases, we see the opposite. Less optimal methods are used, and then we see favorable results. But when optimal methods are used that actually fit the data characteristics much better than, for instance, complete case analysis, the conclusion changes, and then something is not cost effective anymore. And this is illustrated like this in a CE plane and a cost effectiveness acceptability curve, where we have these red dots. These are complete case analysis, bootstrapped cost and effect pairs, because this concerns trial-based economic evaluation. And we also see that the probability of cost effectiveness really decreases to around 50%, which means that we have 50-50% of being cost effective, yes or no. Although it would have been better if I would have shown you an example where it was the other way around, where the complete case analysis was favorable and the optimal method resulted in an unfavorable cost effectiveness. So I'm being called, I'm sorry. So this is the way we look at the results, and we try to identify most optimal methods. If we determine that a certain methodology is not correct, in some cases, we redo the analysis ourselves. Unfortunately, we have a legal time period that we have to adhere to, and we cannot do full analysis within this given time period. So sometimes we just send back the pharmacoeconomic models or analysis and ask them to change the things that we think are most fit for the situation in order to decrease uncertainty in order to make sure that we can make right decisions and avoid a waste of scarce resources. And as I said before, in this case, we are actually assisted by a scientific advisory board that helps us back up our conclusions regarding the methodology. So it's not just someone can come and say, just change the method. No, that's not how it goes. It's mostly backed up by really academic evidence. The last point, whether more research would be useful. In some cases, yes, in some cases, no. And when it's not useful is, for instance, when cost effectiveness is mainly dependent on the price of a drug. There is no uncertainty regarding effectiveness, no uncertainty regarding other issues. It's only the price that makes it, that makes the ICER unfavorable. So in that case, more research would not be necessary. In some cases, when we have lots of uncertainty around the effectiveness, for instance, we have had a submission where the effectiveness was based on a phase 2 trial with a very small sample size and a short follow-up period, we would like to have more information regarding the effectiveness because the effectiveness was not sure. And that can obviously have an effect on your outcomes in your model. But what do we do when we find something to be above or below the ceiling, the reference value? First of all, remember, as I said before, we have a knockout criteria. If it's not cost effective, we're not going to consider it whatsoever. We have an additional step when we talk about effectiveness and cost effectiveness, and that is a public debate by the Insured Package Advisory Committee. And this committee consists of various experts, various people, philosophers, economists, medical doctors, surgeons, patient representatives, that actually look at the medication and the drug and look at the ethical and societal considerations. So in some cases, interventions or drugs might not be cost effective, but ethical and societal considerations are weighing much more than the amount of money we want to pay. So when something is cost effective, we can still determine other ways. We can still tell we advise the minister, and we tell the minister, please, there is too much uncertainty. It is cost effective. It falls below the threshold, but the uncertainty is too large. So please negotiate prices with the manufacturer to increase the probability of cost effectiveness, for instance. We also use conditional approval. So for instance, with that phase 2 trial that I told you before, there was an amount of uncertainty around the effectiveness, but we conditionally approved it with the promise of the pharmaceutical company to give us more data while the intervention is being used in practice. And afterwards, we can check and go back whether their claimed effectiveness at the beginning could be determined, could be seen in practice. And when it's not cost effective, as I said, it's not set in stone. We can still reimburse it because there is an urgent need. We can negotiate prices until it falls under the reference value, but we can also ask patients themselves to co-pay. So a specific amount is paid or reimbursed by the government, but a small amount that is over the reference value is being paid by the patients themselves. So I hope you have an idea of how the system works in the Netherlands, and I'm sorry for the interruptions in between. I'm being called and so on and so forth. But I hope you can put it into context with the Egyptian system, and I'm really looking forward to how the Egyptian system looks like. And if you have any questions or whatever, email me, contact me. I'll be here. You can send me a chat, and I'm looking forward to the discussion. Thank you very much, Will.
Yeah, thank you very much, Mohammed. I think it's very, before we go into a break, are there any questions to Mohammed? Please feel free to ask to anything you would like to know. One of the questions, Mohammed, is will you share the PowerPoint with us?
Yes, I can share the PowerPoint with you. Yes.
Yes, we will share both the presentations afterwards.
I think it's also being recorded, right? So you can also have a look at it afterwards again.
Yeah, I think it's a lot of information already about the Dutch HTA system. Thank you very much, Mohammed, for the introduction. Maybe there are some questions for you still after the break that people think in the break, oh, maybe this is something I forgot to ask. So I propose to have a break and then we can let the information land in our heads and then continue. I will shortly retouch the Dutch HTA system to wrap it up a little bit after the break and then align it with the Egyptian system with some statements as well, and looking forward to a discussion as well about the differences between both systems and what we can learn from it. For now, thanks for the participation already in the first part, and maybe let's have a break. It was, I think, an information intense beginning of the session. Maybe good to have a break for at least 10 minutes, that we continue 4:05.
Okay. Thank you, Dr. Mohammed and Dr. Raoul. Thank you very much.
You're welcome.
Again, Mohammed. Again, Mohammed, thank you very much for your part about the Dutch HTA system. Are there, after the break, any questions left for Mohammed that wouldn't touch up with in the first part of the presentation? Okay, if they are still there during the discussions, let me know. And Mohammed, could you moderate the chat for me? Because indeed I don't see the chat during putting up the slides.
Yes, I will.
Oh, cool, thanks. Okay, let's then continue. I will shortly, as said, retouch the Dutch HTA system, and please correct me when I'm wrong, Mohammed, if you see anything that's lacking. So generally, our HTA system consists of two parts, so the market entry procedures and reimbursement procedures. I mainly show it now from perspective also from our consultancy Ask Academics, in which we are mostly on the other side of the bridge, in which we support pharmaceutical companies to get products reimbursed. So it's maybe a different view on the HTA system, but worthwhile to share with you. Drugs have to enter the market in the Netherlands through, there are two procedures. So there's a centralized procedure, where the European Union is responsible for the market access authorizations, the EMA, also well known. After the EMA, it goes to the decentralized procedure, and there's only possibility for a few EU member states. To see, we have Netherlands. We have actually we make a difference between on the one hand we have pharmaceutical care in our outpatient system, on the other hand we have medical care in our in-hospital system. And as you can see here, it eventually ends up also in a different chain with respect to the DBCs. So you see, for the pharmaceutical care, we follow an outpatient system, and reimbursement is regulated by the outpatient reimbursement system, the GFS, Geneesmiddelenvergoedingssysteem. The in-hospital system is the hospital care, and there the medicinal products are financed from hospital budget and DBC budget. DBCs are in the Netherlands diagnosis treatment combinations, and the other are add-on DBCs for expensive medicinal drugs. So you see, there is really a difference in our country with respect to pharmaceutical care on the one hand and the hospital care on the other hand. Okay, then a little bit more about our outpatient system. So that's the pharmaceutical care, goes to the general registered medicinal products or orphan drugs. And there you see substitutability. So on the one hand, you have, if it's an orphan drug, yes, it's listed in a certain cluster with a maximum of reimbursement. If no, it goes into, let's say, a more specific reimbursement system with subcriteria based on their indication, the age group, route of administration, and clinically relevant differences. And there you see actually that it's based on, it goes into list 1B, and there's no maximum on reimbursement. So this is the general thing to take away from the outpatient system, is that actually there are two pathways of the products. One is whether it's an orphan drug or not, or a general registered product. There you see it goes into a maximum of reimbursement. The other one actually is based on also subcriteria and focused on there's no maximum of reimbursement generally. And what also was touched upon by Mohammed, you see the most important parts we of course focus on now are the added therapeutic value. So first of all, you always show, of course, I think that's the same with the Egyptian system, the clinical added value of a product. And from there you go into the cost effectiveness and the budget impact. We make a difference in the Netherlands with respect to cost effectiveness and budget impact. On the one hand, you would like to show actually statically that if, for example, this product would be evaluated once, that this is a cost-effective product compared to its comparators. So you normally see, I think that's more or less the same, that there is a new product on the market by a pharmaceutical company. There are a few comparators which are, let's say, the competing products on the market already or almost on the market. You compare both. That's kind of the static cost effectiveness. The budget impact is more focused on the perspective on how much you have to invest for the product and whether that is also positive or not. And there you see already more the shared allocation of the budget of the Dutch policy, in which is more focused on, okay, we have a certain amount of fixed budget that we have every year. And from that perspective, how much can we allocate to this product, yes or no? Which is, of course, related to cost effectiveness, but it's a different ballgame. I think indeed this is also included in the analysis of the Egyptian system, but we come back to that. The in-hospital system has actually two different types of products. You have the medicinal products that are financed from hospital budgets, as mentioned, so the DBCs, and the add-on DBCs for expensive medicinal products. This creates this aspect of in-hospital care is, from the one hand, I think a strong aspect of the Dutch system, because this makes hospitals also more let's say, not only responsible for the care they give, but also that they are, let's say, in charge of the type of care they buy for their patients. On the other hand, we see that this might give a kind of enters the heterogeneity among different areas in the Netherlands. So we see, for example, that in areas where there is, for example, a medical center that's aligned with the university, that there's a different way of buying in care than, for example, in an urban area. And as such, you see also that this might kind of incline that there is a difference in the level and the quality of care per region, driven by urbanicity. But it's actually, of course, another topic, but it's something to keep in mind that these decisions you make on the system that you have often relate to certain incentives. So in this way, it's of course something that is just out there, it's a difference that we observe, but also financially, it might create differences between regions but even within regions, if there are, for example, multiple hospitals within a certain region. This is different from the pharmaceutical care, which is on, let's say, an accurate level of the entire country. Shortly about the add-on procedure. Here you see actually that it indeed depends on the budget impact that it has. So, for example, it's now declined to 2.5 million. It was generally 10 million. And you see there is still a kind of way of assessing the product, not only on its cost effectiveness, but also how much it costs to invest in the product. So despite the fact that it's maybe already cost effective, there's a step in the Dutch HTA agency looking specifically at the budget impact of the product. So this brings me actually to the first statement. For example, one of the statements could be based on this impact generally on budget impact and the fact that orphan diseases only apply to a little amount of people, that you might say, okay, we say that medication for orphan diseases should not be insured and only going by the private market. What's your opinion on this statement?
I'm thinking that maybe for orphan diseases, you could reach like an agreement or something like risk sharing agreement, so that it would like maybe reduce the burden on the buyer, but would still like enable patients to access the care.
Okay, I think that's a really interesting point. Is it also something that is already, how does it actually go in the Netherlands, Mohammed, with respect to orphan diseases? Is there already kind of risk sharing system in the Netherlands or not?
I'm not fully aware of a risk sharing system, but I am aware that typically there are systems where the medication automatically becomes part of the health insurance system. And afterwards, cost effectiveness is being reimbursed. And typically it's much more difficult to remove something from the system rather than including it in the system. Typically it is included, mainly because our system is based on solidarity.
Is that similar in Egypt? Is there also already kind of a fixed system for orphan drugs? Or is it just assessed in the same way as the other general drugs?
To my knowledge, till now, I don't think there's a specific system for orphan drugs. But in the new guidelines, I think they're going to be addressed. Like we have the UPA still being established here in Egypt for HTA assessment for reimbursed drugs. I think they will be acknowledged that orphan drugs would be would have like certain rules different from other drugs. Maybe observational studies will be acceptable rather than clinical trials. They would have like their own rules. I think.
Yeah, their own niche, right? Because you have such an, let's say, small sample that you cannot really rely on clinical trials. It's very difficult to rely on clinical trials. Do you see that as well, Mohammed, in the Netherlands, that, for example, that we rely on our evaluations more on observational data rather than clinical trials?
That's a very difficult issue because, I mean, real world data, observational data is starting to become really relevant lately and to use in reimbursements. But I have to say that the National Healthcare Institute is a little bit stubborn and prefers real data or real data. I don't want to say real data, but prefers trial data in order to substantiate the clinical effectiveness of a certain certain drug. So in a sense, there are developments going on starting to include observational studies and those kind of studies, but it's still like in the beginning phases. It's not really part of the part of routine.
I think it also connects more to the second topic of today about machine learning. There you see also that there are different type of methodologies coming into play in the reimbursement scheme, also in the Netherlands, because we are going to rely more and more on observational data. But I think an interesting topic, because you see more and more assessments of orphan drugs. And do we think that this is a good trend, that we get more and more orphan drugs on the market for specific diseases? Or do we think that this might affect our, let's say, time that we spend on diseases that are already in play or already, for example, focusing on the larger part of society? So what's your opinion on that aspect? Do you think that we are spending too much time on orphan drugs and that we should use this time for, let's say, spending more times on diseases that are affecting the large society? Or is it a good thing?
I personally think like prioritization would have to happen at some point, especially for a country like us that's still working on assessing and evaluating new medications. You'd have to prioritize at some point, but maybe like not leave the orphan drugs out of the plan, but give priority to more prevalent diseases.
Yeah, and I think it gets even, I totally agree with that, Noura. And I think we have the same problem or the challenge, you might say, in the Netherlands. And you see that as long as it doesn't get a face, it's a quite easy topic. But for example, in the Netherlands, we saw when in the media it gets a face. For example, we saw in a very famous talk show in the Netherlands that a certain drug was evaluated. It was too expensive. They were decided by the Dutch agency to not reimburse it. And it only affected a couple of children. And if you read it like this, it only affects a couple of children, you might overread it and think, okay, but that doesn't, it makes sense. If it's, for example, over 300,000 euros per child, it makes sense maybe to not reimburse it. But once in this talk show, the child was invited together with her parents. And if you then, for example, listen to for 1 hour to the story and you hear all the emotions, etc., there in the country, it was really something I think was 3 years ago. It really became a big, huge topic, whether we should place money on a child's life or not, and that we could even make these decisions. So I think this prioritization it will become, with increasing healthcare costs, be more and more a challenge for the coming years. But orphan diseases will really be, let's say, in the top of that agenda.
If I can add to that,
yeah,
Roel,
please do so.
Perhaps also very relevant for the HTA agency in Egypt. In the Netherlands, since 2015, the reputation of the National Healthcare Institute improved because we started to tell the world that we're not only looking at money and we're not only looking at cost effectiveness and so on and so forth. While before, like the example you mentioned, Roel, with the kid and the face and the exempting them from treatment, really gives HTA agencies a bad name. And I think also in Egypt, all over the world, we should be aware of that we have in some groups, we have a bad reputation, but we're actually there to improve health for the whole society. And in some cases, we need to make hard decisions. And yeah, it is really, really hard and really difficult. But I mean, I just wanted to add this.
Yeah. Yeah, I think that makes it even, as said, if there's a phase on the decision, it makes it even more difficult than if it's a static thing. So the other one was the budget impact threshold of the add-on procedure, 2.5 million in the Netherlands, is beneficial for overall health. So the question here is, do we think that it's a bit in line with the previous statement, but do we think that there should be a maximum with respect to the costs of a new product, even if it's very cost effective? So for example, let's take Egypt as an example. There's a new product that can come on the market. It is really cost effective, shown in every way, but nevertheless, the impact is so high on the budget that it might, for example, decrease the budget allocated to schooling for children. Is this something that we still think that it's then therefore good to have this threshold? Or do we believe that health should always be priority if something is cost effective?
This is really a personal opinion here, but I think, of course, health should be a priority, but it's only like one of the few necessities of life. You still need food, you need drink, you need security. There are a few other aspects to having a good, decent life, I think. So there should, in my opinion, be a threshold for how much your budget can take. Like I said, especially with a limited budget, like in certain countries, it's important to evaluate how much you are willing to pay for one treatment if you have more pressing problems to attend to.
Yeah, I believe so too. I think it's again really difficult. Is there someone with who would like also to share his or her opinion about this? I think generally, because it's of course a very difficult topic to go over. You see it also in the Netherlands that, for example, if you combine it with other discussions, like for example, indeed food or housing, or also, for example, schooling, then it becomes a different aspect, right? If you just solely focus on health, it becomes easier to have a strong opinion to say, okay, but health is really important. But you see, indeed, it's all entwined. You cannot say, for example, okay, we're going to reimburse this product, but it might, or for example, we're going to insist a certain family to pay out of pocket for this product. Otherwise, the health is such deviated that the quality of life is increased by too much. But if it ends up that this family, for example, loses its house, or the children cannot really afford schooling anymore, then this will come back to health anyway. That's kind of my opinion always with these kind of things, that it's too much sometimes seen as two separated things, that you can say, okay, schooling, housing, food, and the other necessities are not exogenous of health. It's are all entwined. So I think it's indeed good to have kind of threshold for this. But yeah, I think again, I totally agree with you, Noura. It's really in a personal opinion and also situation, the situation dependent. So
yes, exactly.
Yeah, it's so yeah, in this moment was also kind of in the presentation. We would like to ask you any questions about again about the Dutch HTA system. Still also for Mohammed or me. We go now after this part to the Egyptian system and the comparison. Are there at this point any questions?
You can unmute yourself if you have any questions. I added the option, everyone can unmute himself if they want any questions.
Hi everyone. Actually, this is Mohammed Rafat. Actually, I'm working in Saudi Arabia, but I don't know the situation in Egypt. If they have well-established health technology assessment system or not. I think Noura can add something to this issue.
Yes, of course. We're here in Egypt. Like recently, a year ago, we now have the UPA to assess the new interventions for the universal health insurance in Egypt, but it's still first steps. It's still early days. It's still getting established. The guidelines are kind of outdated. I think 2015 or 2013. Newer ones are getting published soon. So it's still getting set up here.
So UBA has its own HTA assessment, not the government sponsorship.
It's not exactly a governmental institution, but it evaluates products that are going to be reimbursed by the universal health insurance by the government.
But regarding the private sector, is there any communication with the private sector to be inducted during this assessment?
Yes, of course. This is a bit above my my level, but to my knowledge, yes, I think so. And there are the HTA office. We are a private evaluating company for pharmaceuticals.
Okay.
And to my knowledge, yes, I think the government is in negotiations with the private sectors to have consensus on the guidelines and how this is going to go.
So Raul, what do you think we need to be or to establish HTA in Egypt within governmental sponsorship? What do you think? What is the methodology to start this step in Egypt?
I think that's a great question. Thank you for this, Mohammed. It fits perfectly to the rest of the slides, in which we go into the Egyptian system a little bit more in detail, and in which we also have a comparison and tools which we believe we might, for example, assist to further develop the Egyptian system. Because indeed, this is a kind of what we see in non-Western countries, one of the most important aspects, that HTA is not yet really embedded in the government itself. It's more something that's either an academic aspect, just there's only some academic knowledge already there, or it's just a kind of private initiative, but really well established in the government, but still a private initiative, which is still, for example, not focusing on accessibility for all citizens. And it makes it also really difficult for these initiatives to get acquainted with the governments. But we will get back to this also in a minute, because I think it's really an important question. So shall I try to answer your question with the slides, and that you let me know if I did well, or that I still have to answer this question?
Sure.
Okay, cool, thanks. So what we see, for example, if we compare Egypt with the Netherlands, we saw with the data from the World Bank might be already that it needs an update, but just to look at it, we see that generally there are, of course, more inhabitants. We see a lower GDP, which takes our eye, and as well we see that there is a lower investment from the government of the GDP in healthcare, and this is quite striking. If you see the difference in GDP and the difference in percentage points, you see that there's really a lower investment in healthcare in Egypt with respect to the Netherlands, and also that the out-of-pocket expenditures is significantly higher, almost six times higher than in the Netherlands. And this raises already kind of the question that if out-of-pocket expenditures is at such a high level, then it induces, of course, that richer people have higher accessibility to care than the people that are poorer in a country, are more poor. So in that sense, also I think with respect to the socioeconomic differences in health in Egypt, that they are way larger than in the Netherlands. Is this something is this assumption well estimated, you believe, Noura, that there is in the Egypt, let's say, a really large difference in accessibility to care based on the level of richness of the families?
Yes.
Yeah, yes. The out-of-pocket expenditure in Egypt is an urgent, pressing topic to be addressed. I think it's the percentage looks about right here.
I think maybe much more, like 70 or 75% out-of-pocket market in Egypt. So I think it's difficult to establish this type of assessment in this fragmented market or out-of-pocket market. Do you agree with me?
Yeah, I totally agree with you. That this is kind of There's also one of the policy goals we saw from the Egyptian government for 2030 to really focus on this out-of-pocket expenditures, and that's where it all starts, right? So if you cannot really decrease this, it's difficult for the general healthcare to let's say, okay, if we have this reimbursement system, this is, let's say, the second step after this. So indeed, we should focus on this to, let's say, to put it a little bit more in perspective there, the Egyptian HTA system, we saw actually a specialization in CAPA departments. So you have the procurement department, the pricing committee, and the pharmacoeconomic unit. It is kind of establish and elaborate review protocols and multiple tender lists for different drugs. And as you can see here, there's in the overview, there's a cabinet of ministers. There is a Ministry of Health, of course, divided by the Health Insurance Organization and the Egyptian Drug Authority, the EDA. And there you see a split from the EDA towards 3, let's say, smaller departments. And from there, they are, as mentioned, responsible for the main part. My question to Noor is actually, is this EDA really proactive in play with respect to reimbursement of drugs?
I'm not fully aware of the exact tasks of EDA, but what I know is at this point they are responsible for like registering and approving new medications to the Egyptian market, and they do have a pharmacoeconomic unit under CAPA, as you said. Yeah. But in terms of economically evaluating medications, I don't know how the percentage of new interventions that are being economically evaluated at this point.
That's, I think, something for a follow-up task to really dive into together to see how much already goes through via this system that's in play. And if you then compare with our system, as shown, I think, a couple of slides ago, you see already kind of the difference that we go, of course, also by European aspect, that we are a country of the European Union, and there's no general African system that we are aware of. For example, that drugs are focused on the African as a full union and then separately to the countries. So it's really country specific. And there's really in our country a difference between market access and reimbursement, which are of course in play together, but are really different entities in the Netherlands. So to wrap up the differences, we would say we focus mainly on essential drug reimbursement in Egypt, whereas the Netherlands also focused on technological and expenses novelties. So you see in drug reimbursements in Egypt, it's more or less for now really focused on essential drugs and not on the, let's say, the additional aspects that we already see in the developments with respect to HTA. The Netherlands uses different lists for orphan drugs and substitutable drugs, whereas Egypt has a single list. So there you also see if you make kind of differentiation in lists per products, it might give you a better grip and overview of the products that get market access or not. And the add-on system in the Netherlands allows non-tender and in-hospital drugs for orphan diseases on the market, which actually gives a little bit more freedom with respect to the activity of orphan drugs also in the Netherlands. But I think these aspects all were also shown in the overview of the two systems. If we then list these differences and we look at these, to go back to your question, Mohammed, if you now see, for example, the differences in the systems, what would be something, for example, from your perspective, knowing this out-of-pocket expenditures in the back of our minds, that might be one of the first steps to take from the perspective of the Egyptian system?
Thank you, Rob. Thanks so much.
And that comes actually to the to one of the statements. So what is your opinion in general on that is private healthcare, which induces the out-of-pocket expenditures, because it's mainly regulated by private healthcare? Our general way would say that we, for example, the statement is in this sense that private healthcare has a negative effect on the quality of care in public healthcare. Is this something you agree to? Or do you think positively about private healthcare in general? Any opinion is welcome. So feel free to-
I can add that private healthcare can support the public healthcare, not substitute it. And as you mentioned in Egypt, I think 75% or 60% of the healthcare in Egypt is private sector. So I think we must minimize the role of private sector within the healthcare. As you know, it's a governmental responsibility, not just a private responsibility.
Is there a different opinion than this one? So is there someone who likes to add something to the opinion of Mohammed?
I think, I'm sorry, did I interrupt Dr. Mohammed?
No, go ahead, go ahead.
I think I disagree a little bit with the statement. I think private healthcare, especially with a situation like in Egypt, could be utilized to assist the government in a transition phase where they are moving toward better health services. I think private healthcare could be very beneficial, at least in this stage.
If I might change the point of view here. So if you look from the point of view of a patient, in my experience, I am from a Moroccan background and I have family living in Morocco. It is a relatively similar country in terms of culture and the rest and so on and so forth. The reputation private clinics and private healthcare has is much better than public healthcare. Isn't that also a thing that we need to, or at least should be taken into account? Because typically people think, oh, private healthcare is more expensive, so it's better. Well, necessarily that shouldn't be the case. But that's something perhaps to think about, that the point of view of the patient should also be taken into account. I'm not sure whether that's the same in Egypt. In the Netherlands, I can say it's not really, the public healthcare here is actually even better or as good as private healthcare. There is not much of a difference, but then if I can speak for the country of Morocco, I think the difference in private versus public is relatively large.
I would say Egypt has a very similar situation to Morocco, of course.
And indeed, I think that comes back to, one of the most crucial questions raised by Mohammed Rafat, that in that sense, of course, so far, the HTA regulations are mostly focused on public healthcare. But if public healthcare is a relatively small aspect of the country, and you try to really increase the HTA agency and make it a perfectly running system, focusing on maybe only 25% of the healthcare of a country, while on the other hand, there is just a private healthcare market of different type of hospitals, different type of care, and which richer families could say, okay, if I spend a little bit more money, I ignore this regulated system and my family member can have better healthcare. You will never, let's say, change the chain between rich and poor with respect to access to healthcare and the quality of care if you only regulate this 25%. So indeed, I would say indeed one of the main challenges with respect to the developments of HTA agencies in countries like Egypt is try to embed really the HTA regulations, like I think amazingly already starting by the HTA office, also for the private healthcare. Otherwise, it would be only running a very small aspect of a country more perfectly, instead of focusing on the true problem or challenge, you might say. So yeah, thanks both for really your inspiring examples and giving us more insight on how it works. For example, also Mohammed in Morocco, and I think that relates perfectly to Egypt. The other one is, I think, quite related, the statement, because you can make, for example, a system more detailed, but it maybe doesn't mean it becomes a better running system. So one of the final statement of this aspect of the presentation is that creating multiple lists for different types of drugs makes the system unnecessarily complicated. So to put it in perspective, I think we in the beginning mentioned, Noura, about, for example, orphan drugs. Do we agree that it's better to have different running systems for different type of products, or should we just have one system for all products, whether it's an orphan drug or focusing on a general disease? That's the main question.
I think I would agree with the statement. It would make sense to compare products with similar backgrounds or similar areas of action, I guess. And then still while prioritizing from a larger perspective or the larger picture, what is more urgent than what.
Yeah. Maybe good to have directly the opinion of our Dutch HTA advisor on this, because of course we have multiple lists. What do you think is the biggest advantage of having differentiation in lists?
Raoul, you mean here in this statement the reimbursement list or prescription list? And the list that may be used during the prescription from a treating physician or during the access and reimbursement list with the tender?
The reimbursement list.
Okay. I think one unified list is more better for the system.
And maybe could you also ask to Mohammed El Alili. So what, for example, based on the perspective of our Dutch HTA agency, what could be the advantage of having multiple lists?
In the Netherlands, we actually have this to classify drugs in terms of their effectiveness. So we can group them according to each other. So for instance, we have, correct me if I'm wrong, because I always mix them up, because we have the 1A or the 1B list, I'm not sure. But it means that the effectiveness of the two types of drugs are the same, which means that there are a number of restrictions, but that is for that specific type of drug that has an equal effectiveness as the other drug, the maximum price is the price of the drug that is already available. So these types of choices can be made while we group drugs according to their effectiveness, or when it's about adding or like expanding an indication. So for instance, there might be it's a SGLT2I inhibitor. It can be used for diabetes, but it can also, but very smart sometimes, there are different indications that are used. So you can either submit an HTA submission for this specific drug for patients with diabetes type 2, but you can also say in the next submission, I want to try to submit this drug for patients with diabetes type 2, including cardiovascular diseases. But if this affect, so the way they work is relatively similar. So we also have to look at the costs. And in that case, we can make sure that not too much is paid or reimbursed. So in that sense, I see it is relatively difficult, but it also has a benefit by being able to group the medications according to their effectiveness.
So yeah, I think in that sense, it really depends indeed on already the structure in play in the country. I think indeed that multiple lists might be an advantage if you already crossed other challenges with respect to the development of the HTA system. But we will come back to that also in more detail on the follow-up activity. So yeah, we are very happy, as announced in the beginning, that we have started the collaboration with the HTA office to further see actually what opportunities are with respect to closing the gaps between the differences in systems and what we can learn from each other. We already developed a few opportunities. I will stop sharing my slides. Already actually developed a few things that we thought of already to discuss. For example, we might say indeed focusing on this different list of the different kinds of drugs, see whether it might have a kind of advantage also there for Egypt to improve the reimbursement and to create more economically efficient healthcare. But one of the most important aspects will be indeed to focus on the development of a reimbursement system that is really focusing on the main challenge of decreasing out-of-pocket expenditures and makes it fairer for the poorer people. And this is, of course, something really in collaboration with the government and things that are goals that we have on the longer term. But I think they are worthwhile to really focus already on a short or midterm on the activities that should be in play. Besides that, also capacity building to see are more and more methodologies coming in play with respect to reimbursement procedures, and to see whether, for example, we might, for example, already step into that, improve with that aspect the qualities of the HTA methods, and as such decrease the cost of healthcare. Most importantly, I think for the coming period is to get further aligned with how the system works and what we can add to it. But for now, I think I really would like to thank the entire audience for your participation and all your interesting questions, but also your input on the slides that we had and the information that we told to you about the differences between the systems and how actually the Dutch system works and how it might be, for example, something that we can get out of it for the Egyptian system and the other way around. I would like to use the final time of final 15 minutes for any final questions. If you have still any questions there for me or for Mohammed. So please feel free to ask anything you would like to know.
Hi, Ruel.
Hi, Gian. Hi.
Yes, thank you so much. I'm trying to catch up. Sorry for being late to join our meeting, but actually I have a meeting at 1 and then moved to 3 p.m.
Yeah.
So there is some.
It happens. I have the same in the second part of the meeting. I think it comes with roles, so it's no problem. Totally no problem.
Okay, no problem. I want to thank you first for your presentation. I'm trying to catch up when I was driving from a little while, but want to ask you more about what do you see. I don't know if this question is being asked before or not, but I'm very curious to know about the differences or the real differences between your healthcare system and the Egyptian healthcare system. I'm sorry if this question was asked before. I'm not catching up as I tell you, but I want to know more about this.
Yeah, of course. So of course I will also send you the slides and we can have a follow-up call on this. It puts it more in perspective here. What I think the main aspect here on what we focused on, and also I think the one of the most crucial questions raised by Mohammed Rafat is that you see that there's still a lot of out-of-pocket expenditures in Egypt, which means that privately a lot of the care is regulated, actually driven by the fact whether families are poorer or richer, and in that sense they can have more accessibility to care. While in the Netherlands, we see, also discussed in our first meeting, that, for example, we have only less than 3% is not insured. So mainly the main part of our care is just driven by public health care. So it's quite equal for all families. Of course, there's still a part out of pocket, but we have a kind of pooling risk system in which we all, as a kind of solidarity, are responsible for each other in our country with respect to accessibility and quality of care. In Egypt, you see, there is, let's say that 25% of the care is regulated by a public system. And in that sense, you see that there's also difference in the way drugs come to the market and also are evaluated before market access. And I think this picture puts it already in perspective. But there are also other slides aligned to this. So I'm happy to share with you afterwards. So I think mainly the difference is that still this out-of-pocket aspect is, I think, one of the biggest challenges aligned to developing an HTA system that is going to focus more on this.
Yes, but I think the Egyptian healthcare system has now been changed. I can share with you the new structure of the Egyptian healthcare system. Now we have Unified Procurement Authority, we have the Egyptian Drug Authority, and we have the universal healthcare coverage. So there was many entities and many institutions have been raised from a little. But actually, we are moving to a new era. I think this new healthcare system in Egypt will transform the decision making, the tools that they use in taking their decisions, and also many bodies in Egypt actually want to build an HTA. So you will not see a unified body for HTA, but actually I see that you will find many HTA bodies in many organizations. So I think yes. Yes, I think like US, I know that they have many HTA bodies in the country, not like UK. UK have only nice, but I don't know if your country already has one HTA, one national HTA, or they have different institutions.
Yeah, we really have one national HTA body. Also because we have learned, for example, from the US that if you have still, for example, first of all, I think it's an amazing development already in your country, what you mean with respect to more entities focusing on HTA, and that definitely helps, of course. One step further is to try to get these entities aligned, because you see generally, for example, in the US still, that there is so much difference in how drugs are evaluated per region, that still this creates a kind of regional differences with respect still to the quality of care and the accessibility of care. And of course, there are a lot of pitfalls as well with a national full HTA body, but I still think with respect to creating more equity in society, it's kind of in favor to have one HTA body, but I think that's something at the end of the spectrum. I think already having more entities in play is a great development. Yeah.
Perfect. What is the role of different universities in your country? Does they already have a role in HTA?
Yeah. So what you see, what you see, we have in general 11, let's say, official universities in the Netherlands. I think in half of them they offer programs in health technology assessment. So both on the undergraduate level and the graduate level, but also PhD programs. And there you see a kind of the transitioning from master students, so graduate students or PhD students towards the HTA body is quite efficiently. So you see that there are, like, for example, Mohammed El Alili is the perfect example, I would say. He just finished almost his PhD and is now started as a pharmacoeconomic advisor at our Dutch HTA agency. So you see a lot of, and still a postdoctoral researcher in HTA. So you see still a lot of people, I believe also Mohammed, working at the Dutch HTA agency are still researchers, right?
Yes, there is an overlap between HTA researchers that actually also work at the pharmacoeconomic or the HTA agency from different universities, like from Rotterdam, from Groningen. But we also include, at the HTA agency, we also try to include them in our decisions. I mean, the expertise, the real expertise comes from universities with the professors and the experts in the field. And we typically ask them to double check our work. And if we have any questions regarding methodology that we don't understand, and so on and so forth, we typically reach out to universities. So they have a very active role in supporting the HTA agencies. And I'm not sure how it is in Egypt, but I think that would also be very beneficial for you, because I have the impression universities are less, much more independent in the way they approach methodology and trials and results and so on and so forth. So those are the groups that you can ask for typically methodological issues. But when it's clinical expertise, typically we turn to clinical experts from everywhere, from universities to hospitals to that actually also double check the work we do with the HTA agency.
Perfect. Okay, but does this guidance is mandatory to the decision-making bodies, or it's like just a guidance, or could it be implemented or not?
If I understand your question correctly, is whether we have to reach out to the universities or to the experts from university, right?
I mean that, for example, if a national HTA or HTA, for example, publish a study about cost effectiveness of a certain product, does actually the decision-making body consider this, or make it it's like a kind of research, not a mandatory, or not they can they cannot guide us.
We look at published cost effectiveness analysis, definitely. But HTA submissions typically are not published. They can be very high level analysis and very high level reports, but typically we don't publish them on PubMed or whatever. But cost effectiveness analysis that are published by different groups are typically looked at to put the HTA submission into context. What did the pharmaceutical company find, and what does the literature find in different countries, and in the Netherlands, for instance, or in the US, or to put it into context.
And maybe if I may add to that, because what we see, for example, in my other role as director of the consultancy in market access and health economics, we see a lot of requests also for pharmaceutical companies, not only to assist in market access and reimbursement via the Dutch HTA agency, but after reimbursement, we also see that sometimes a product is not really used yet that much. And then they would like us to, for example, write a promoting article in a Dutch magazine, or for example, an international paper about the product, actually doing the same analysis all over again, but then in a scientific way, and publish it to get more attention for the product. That's what you see more often. Yeah.
Perfect. Thank you. Thank you so much.
Yes, and yeah, thanks again. Also, I said it also in the beginning. Thanks again for inviting me as well for this chapter meeting, and looking forward also to the second part. Maybe give everyone, because we had a lot. I think we had a lot of information in a short amount of time. Maybe we can have a break shortly for everyone, and then happy to also hear more about your topic, Gian, about machine learning.
Yes, sure. We can take 5 to 10 minutes break, and then we can come again in 5:10. Did you have a break before or not?
For me sounds perfect.
Yeah. Okay. Okay. We can take just 10 minutes break, and then come 5:10.
Yeah. Perfect.
I have to leave, unfortunately. Thank you, Roel, also for inviting me for today, and it was a pleasure talking to you, and hopefully in the future we can find some nice collaborations and organize some nice talks together again. So thanks again, and if you have any questions, you can email me, contact me via LinkedIn or whatever, and I'll share my presentation. I think I'll send it to Roel, and then Roel can send it to Jihan. And yeah, this session will be recorded, right? So if someone can send me the recorded session of this part, so that I can also have a look at the machine learning part in my time, because I have some other things to attend to.
Yes,
thank you very much.
I will, just like you, Guillaume, be in and out of the meeting, and then but I will also definitely see the full recorded part. But looking forward to it.
Sure.
Thank you very much.
Thank you so much. 10 minutes, and we will come again. Hello, everyone. We will start now our second topic. We'll talk about new advancement in health economics, machine learning, and novel values. We will start first with machine learning, okay? And then we will talk more about novel values and get the key home messages. First, when we are talking about machine learning in health economics, we should know first what does it mean by machine learning. So we will talk more about what is machine learning, steps to apply machine learning, and the estimator families for health services research, and the possible applications for this. When we say machine learning, we should know what does it mean. Machine learning is a subclassification of artificial intelligence. I think many of us heard this word a lot from in the recent period. I think artificial intelligence is very important now, not only to healthcare, but for many industries, as we will see today in our topic. This machine learning or this methods is a subclassification of artificial intelligence, as I said. It aims to manufacturing systems capable of learning and improving from experience without being explicitly programmed. Okay, what does it mean? Machine learning is mainly focusing on development of certain programs that can process data and utilize it to learn for future use or to work independently without any interference of humans. So when we talk about machine learning, we should know that this process of learning starts with observations, something like instructions, direct experience, in order to detect patterns in data and take the optimum decisions based on previous experience, based on provided examples, but this is mainly focused on observations of data and processing of certain data and taking optimum decisions. The main objective of machine learning is to enable machines to learn independently without human intervention or without any human interference. And this assistance actually could be very helpful in healthcare and especially in healthcare decision making. There are three types of machine learning. First, decision tree. Decision tree, it is like the already the decision analysis we already know. We all know the decision analysis and how we can make a model, a tree model or a Markov model. Decision tree, it's the same like decision tree already learned in the modeling or in the decision analysis. The purpose of using a decision tree is to produce a training model that can be utilized to predict the value of a target variable by learning simple decision rules deduced from previous data or training data. Okay? Decision tree methods are very valuable for categorizing different subpopulations that have different risks. We have, for example, target population. For example, they suffer from cardiovascular disease. So actually many of them maybe smokers, others already have other comorbidities. So it's very important to categorize these risks in different subpopulations and make some prediction about their outcomes. We have also deep learning. Deep learning is also type of machine learning, but deep learning is more complicated than decision tree or than the already tool used in decision tree. Deep learning here means that we utilize multi-layer neural networks. It's like the human of the brain. Actually, a deep neural network analyzes data with learned representation, similarly to the way the person look at a certain problem. In other machine learning methods, the algorithm is given a set of features to learn. It's a bit of what? It's like a set of features, features the already learned, or for example, we give a raw data and build an algorithm and decide. And actually, this in the deep learning methods, the features are actually they choose the features that are relevant and actually can process this raw data. The larger the size of the given data, the more accurate the algorithm is. But deep learning here is mainly a method of machine learning that tries to imitate how human brain works. That's why this method is very complicated. So it cannot be like a decision tree or something like could be easily done, but actually you should know how to build these algorithms. Okay, let's know. I think all of the participants are Egyptians, so we can talk both in English and Arabic, because I know that machine learning is it's not easy, it's something new. So خلينا نتكلم both Arabic and English to make it more easier. يعني. Okay, I see that all the participants actually are Egyptians or in from the Arabic region. Okay, the third tool used in machine learning is ensemble methods. Okay, ensemble methods دي أنا هنا بستخدم mainly classifiers علشان برضو أعمل prediction، لكن ensemble methods دي already بتستخدم combine multiple machine learning methods. هي مش بس بتعتمد على decision tree ولا بتعتمد على deep learning، هي mainly بتفوكس على أكتر من method وبتستخدم أكتر من tool علشان to optimize the prediction by combining these learning methods. برضو هنقول يعني الناس بس ما تتخضش، طبعا هو mainly طبعا يعني ماشين ليرنينج دي حاجه جديده، بس خلينا نتكلم على الابلكيشنز بتاعتها. انا بس حابه ان انا اقول الديفينيشنز بتاعتها في الاول، وبعد كده مينلي هنتكلم على الابلكيشنز بتاعتها. اوكي طيب خلينا نتكلم على الستبس هاو تو ابلاي ماشين ليرنينج عشان برضو الناس ما تفتكرش ان هي صعبه، لا هي يعني هي ممكن ان هي تتعمل بس مع طبعا شخص بروجرامر، يعني لازم يبقى في حد بروجرامر او حد يبقى فاهم كويس قوي ودارس ماشين ليرنينج وبايثون لانجويج وسيرتن لانجويجز كده عشان يقدر ان هو يبني الالجوريزمز دي. الاول هنتكلم على الداتا بريباريشن، ازاي بنبريبير الداتا، بعد كده هنتكلم على هاو تو تشوز الاستيميتر فاميلي. اوكي، وهاو تو تشوز برضو الاستيميتر بارامتر اللي انا بقدر من خلاله ان انا اعمل ريجولايزيشن للاستيميتر ده. اوكي، واعمل برضو ايفالويشن مينلي للاستيميتر في الاخر. طيب اول حاجه الداتا بريباريشن، ازاي اقدر اعمل او ابني ماشين ليرنينج؟ اول حاجه لازم يكون عندي داتا سيت، لازم يكون عندي بيج داتا، لازم يكون عندي اوريدي داتا سيت فيها الداتا بقى بتاعت البيشنتس. طبعا كل ما تكون اكبر كل ما تقدر ان هي نقدر ان احنا يعني نبني اوتكمز احسن، ونقدر ان احنا يعني نطلع منها very important outcomes يعني. تمام. تاني حاجه لازم مهم قوي ان انا الانيشال داتا سيت دي لازم تبقى organized in a manner that simulate the real world setting. يبقى it should be simulate the real world setting علشان اقدر ان انا فعلا ابريدكت الاوتكمز الصح. اوكي. تالت حاجه عندنا هنا ان انا لازم الاناليست mainly divide the original data set into three subsets. The first is training data set, which is about mainly 70%, and then test data set, and then validation data set. It's very important to categorize or divide this data set into three sets. Why? Because actually the training data set أنا mainly هنا بعمل إيه؟ أنا ببتدي الأول إن أنا أدي الانستراكشنز أو أدي الأوردر بشكل معين علشان تقدر الماشين تفهمني، تفهم أنا عايزة أعمل إيه، أو تفهم الكونتكست بتاعي. بعد كده ابتدي اتست بقى الداتا سيت دي، هل فعلا هيبقى الاكتوال زيه زي البريدكتد، يعني هل هيبقى فيه very يعني minimized error between الاكتوال والاوريدي بريدكتد الداتا دي. تمام. وثالث حاجه بعمل بقى فاليديشن، بتاكد بقى ان اوريدي يعني I can use this machine انها تقدر فعلا تطلع لي الاوتكمز اللي انا عايزاها. اوكي. رابع حاجه عندنا هنا ان انا بانشور ان كل subset is representative of the overall data set population. لازم ان انا انشور ان الداتا دي الموجوده في السبسيت اللي عندي فعلا بتريبريزنت الاوفر اول داتا سيت population. طيب تاني خطوه عندنا هنا الاستيميتر فاميلي سيلكشن. ايه هو الاستيميتر؟ دي فانكشنز معينه، او ممكن نقول مثلا يعني kind of equations معينه، او ببتدي ان انا يعني استخدمها علشان احول الانبوتس بتاعتي الاوتبوت. اوكي، اوتبوت يقدر ان هو يساعدني في اتخاذ القرار. انا مينلي بستخدم الماشين ليرنينج ده علشان يساعدني على اتخاذ القرار. طب خلينا يعني برضو نتكلم، الماشين ليرنينج ده زي ايه؟ زي بالظبط اللي احنا شفناه في الصين ايام الكورونا، لما كانت البوليس او الشرطه وير الكابس بتاعتهم. الكابس دي كان بيبقى فيها مزوده يعني بالجوريزمز معينه. الالجوريزمز دي بتقدر ان هي تديفرنشيت الاوتكمز ما بين الناس. يعني اقدر ان انا مثلا فور اكزامبل لو انا يعني حد من الشرطه ولابس مينلي الكاب دي، هقدر ان انا يبان من خلالي ويبقى فيه نوع من الالرت كده يقول لي لا الشخص اللي واقف قدامي على اليمين ده شخص مثلا درجه حرارته عاليه، او الشخص ده ممكن يكون بوزيتيف كورونا، او الشخص ده عنده مثلا سيمتومز برد. فكان بيقدروا ان هم يبريدكت من غير ما يعني مجرد بس يمشوا في الشارع كده، ويقدروا يبريدكت الناس اللي هم عندهم العيانين او اللي عندهم كورونا فيروس. فبالتالي كنا بنشوف مناظر غريبه جدا في السوشيال ميديا، كنا بنشوف ناس يعني البوليس بيهجم على ناس ماشيه في امان الله وماشيه عادي جدا، تهجم عليها، تقبض عليها وتعتقلها او تعزلها، او يعني مين ان هو ايه يعني تو كيب ات يعني الون خالص، بعيد عن البوبيليشن وبعيد عن المجتمع. ده بالظبط كان تطبيق فكره الماشين ليرنينج وفكره البيج داتا. طبعا الصين اكتر بلد عندها يعني داتا لكل حاجه، لكل فرد بيعمل ايه، عندها بيانات كل حد. عشان كده دي البلد الوحيده اللي ما عندهاش فيسبوك، ما عندهاش سوشيال ميديا، ما عندهاش كل معظم الويب سايتس الموجوده دي، لان طبعا يعني في ريستريكشنز على الداتا بتاعتهم. فطبعا يعني كانت يعني شفنا فعلا تطبيق الماشين ليرنينج والارتفيشال انتليجنس على الشعب ده اثناء طبعا يعني وجود الكورونا، وازاي قدروا ان هم يسيطروا على الديزيز ده بشكل يعني سريع جدا وبشكل فعلا فيري efficient. يعني طبعا في ليميت، يعني طبعا في ليميتلس، يعني عندي ارقام كبيره جدا من الفانكشنز والاستيميترز والايكويشنز. طبعا مش هقدر ان انا يعني استخدمهم كلهم، بس اللي احنا مين هنقدر ان احنا نعمله، ان احنا هنقدر ان احنا نبتدي ناخد فاميلي استيميتر كده او فاميلي فانكشن بشكل معين، وهي دي اللي احنا نبني عليها الماشين ليرنينج بتاعنا، علشان اقدر بالانبوتس دي اقدر اطلع باوتبوت، او اطلع ب يعني قرار معين ممكن الماشين دي تاخده من غير ما ترجع ليا، او من غير ما يبقى في اي انترفيرنس او انترفنشن من الهيومن نفسه. يعني تمام. تالت حاجه الاستيميتر بارامتر ليرنينج. ده هنا الاستيميتر بارامتر ليرنينج انا ببتدي اعمل ايه؟ ببتدي ان انا مينلي يعني كاني كده بجرب انالايزنج الداتا اكتر من مره، يعني بكرر انالايزنج الداتا اكتر من مره، واشوف هل الاكتوال داتا اللي عندي هتطلع بالظبط زيها زي البريدكتد اوتبوت اللي انا طلعته، وهل هيبقى فيه مينيمايزد ايرور ولا هيبقى فيه لارج ايرور. ببتدي ان انا يعني عن طريق الريبيتيشن كده، وعن طريق ان انا بكرر الاناليسيس بتاعه الداتا دي لغايه لما احاول ان انا امينيمايز الايرور ده، او امينيمايز يعني اوريدي الديفرنس بين البريدكتد وبين الاكتوال اوتبوت. اوكي. طبعا بيبقى في نمبر اوف الاوبتمايزيشن للميثودز دي اكتر، يعني بيبقى في عندي فانكشنز كتيره وفي اوبتمايزيشن ميثودز كتيره بتقدر ان هي تساعد وتستيميت الفانكشن بارامترز efficiently وفيري accurately. يعني رابع حاجه بقى الاستيميتر ريجولاريزيشن. يعني ايه استيميتر ريجولاريزيشن؟ يعني انا هنا ببتدي ان انا يعني عندي طبعا فانكشنز كتيره وعندي ميثودز كتيره ممكن ان انا استخدمها، بس انا دايما بختار السمبلست، دايما بختار ان انا يعني افويد الكومبلكسيتي، علشان في الاخر كل ما انت بتافويد الكومبلكسيتي كل ما بتكون دي مور اكيوريت اكتر يعني للداتا، وبتدينا فعلا اوتبوت احنا بيبقى ذا موست كريديبل. يعني اوكي. طيب اخر حاجه بقى الجنراليزابيلتي. ازاي اقدر اعمل يعني استيميتر ايفالويشن؟ استيميتر ايفالويشن هنا مينلي بتست، يعني انا بتست اوريدي النيو انكامينج داتا اللي هي لسه اوريدي الماشين دي ما شافتهاش قبل كده، المفروض ان هي يعني هيتعمل لها بروسيسنج بنفس الشكل، هتستخدم نفس الديستريبيوشن. هيبقى الداتا بالنسبه لها سيميلر، فبالتالي هي هتقدر ان هي تبروسيس الداتا دي وتطلع اوتبوت في الاخر، او تطلع نوع يعني هتطلع لي البريدكتد اوتكم بتاعي في الاخر. فطبعا الاستيميتر ايفالويشن هنا انا مينلي ببتدي اشوف هل هي فعلا لما انا ادي لها اي داتا جديده هل فعلا هتقدر انها تعملها زي الداتا القديمه اللي كانت موجوده، او زي الانستراكشنز اللي انا اديتها قبل كده. فانا هنا بتست ان هي فعلا الداتا دي واوريدي الايفالويشن بتاعه الاستيميتور ده از جنراليزبل على اي داتا جديده ممكن ان هي تتعرض لها الماشين نفسها. تمام. وعندي اللوس هنا، اللوس اللي هي دي يعني بقول عليها كده ليميتيشن دي، يعني دايما انا المفروض يعني فور اكزامبل لو انا لقيت في لوس اللي هو الفرق ما بين الاكتوال والبريدكتد، لو انا لقيت اللوس عندي عالي، لو لقيت الديفرنس ده عالي بين اوريدي الاكتوال داتا اللي عندي والبريدكتد داتا اللي عندي، لو انا لقيت فيه فرق كبير يبقى ده ممكن يكون طبعا نوع من الليميتيشن. ده مثلا نتيجه فور اكزامبل ان ما كانش فيه ماينورتي بيشنت داتا، ان ما كانش فيه تشينجز اوفر تايم، ان انا مش كل الداتا عندي واضحه، الداتا مش كلير انف، الداتا بايزد في اتجاه معين. فدي برضه تعتبر ايه يعني ليميتيشن للتست ده نفسه يعني. طيب برضو الاستيميتر فاميليز بقى دي بقى نيجي هنا بقى مهم قوي ان احنا نتكلم على الاستيميتر فاميليز يوزد في الهيلث كير ريسيرش. اوكي. فور اكزامبل مثلا هنلاقي زي ديسيجن تري. فكره الديسيجن تري ايه؟ ان انا عندي نودز وعندي باث واي معين بيمشي فيه البيشنت، فهي نفس الشكل. يعني مثلا لو جيت انا يعني وريت لكم كده الديسيجن تري هتلاقوا مثلا هنا ان انا بيبقى عندي مثلا فور اكزامبل ان البيشنت ده ممكن مثلا انا اوريدي عندي داتا، الداتا دي انا عملتها بنفس الشكل واديت لها نفس الالجوريزم بتاعها. تمام. وبعد كده ابتديت ان انا اشوف هل الداتا دي هتبقى بروسيسد كوركتلي ولا لا، هل هيبقى في ايرور بنسبه قد ايه، كوركت بنسبه قد ايه. برضو يعني هوريكم برضو اكزامبلز عليها اكتر. طبعا بيبقى مهم قوي في الديسيجن تري دي ان انا ابريدكت ازاي اقدر ان انا اكونسيدر مالتيبل كومبلكس انفلونسز على الريسك اوف الهيلث اوتكم. يعني ايه؟ يعني مثلا فور اكزامبل عايزه اشوف الامباكت بتاع الايج، السكس، السموكينج، الاذر كوموربيديتيز على مثلا كارديوفاسكولار بيشنت. عايزه اشوف الامباكت بتاعه كل الصفات دي او كل الريسكس دي على certain health outcome. تمام. ده ممكن هو يتعمل عن طريق لوجيستيك ريجريشن، بس الفرق هنا في الديسيجن تري او في الماشين ليرنينج ان انا بدخل داتا معينه، يعني بدخل داتا ثابته، داتا فيكسد. لكن في الماشين ليرنينج الداتا دي متغيره، الداتا دي ممكن تتغير اكروس تايم. فعشان كده بتبقى مهم قوي ان يعني فكره بقى الديسيجن تري والماشين ليرنينج هي فعلا بتحاكي اللي بيحصل على ارض الواقع، ان ممكن يحصل تغيرات باي شكل باي طريقه، ممكن التريتمنت ايفكت يتغير، ممكن فور اكزامبل يظهر دواء جديد، ممكن الكوست بتاع الدواء يقل، فكل ده هو حاطط في اعتباراته كل الحاجات دي. تمام. برضو بتبقى مهم قوي لما اجي مثلا انا عايزه اشوف مثلا certain factors زي مثلا اللو انكم، زي مثلا اللونج ديستانس تو الفارماسي. مثلا بيشنت عنده يعني اوريدي دايابيتس وهو خايف انه يحصل له هوسبيتاليزيشن او يحصل له كومبليكيشنز معينه، فببتدي ان انا عايزه اشوف على التارجت بوبيوليشن دي قد ايه منهم هيبقى مثلا ممكن يدفع كو بيمنت. عندي برضو ناس منهم معينه ويز لو انكم، عندي ناس معينه برضو ويز لونج ديستانس للفارماسي بتاعتهم، او ناس مثلا الايج جروب بتاعتها اولدر. فببتدي ان انا اشوف كل الفاكتورز دي على الاوتكم اللي خاص بالدايابيتيك بيشنت ده. فبالتالي عايزه اشوف لما كمان الاوتكمز دي تتغير. يعني انا مثلا فور اكزامبل لما باجي اعمل اي ماركوف موديل او ديسيجن تري وبستخدم السنسيتيفيتي اناليسيز، فانا هنا بستخدم حاجه اسمها probabilistic sensitivity analysis. فانا بستخدم فاكتورز، الفاكتورز دي بتبقى ثابته، الفاكتورز دي بتبقى فيكسد خلاص. يعني هو فور اكزامبل مثلا البيشنت اول سنه هيبقى الريسك اوف ديث عندي مثلا فور اكزامبل 40%، ثاني سنه الريسك اوف ديث مثلا هيبقى 20%، هيقل شويه. دي فاكت عندي. لكن الفكره بقى هنا في الماشين ليرنينج ان انا الحاجات دي كلها بتتغير، الحاجات دي كلها بتتغير، وانا يعني مش هينفع ان انا اتدخل فيها. انا لازم ادي انستراكشنز كده للماشين وهي الماشين اللي تبتدي تو ادوبت او تطلع اوتكمز اكوردنج للفاكتورز دي واكوردنج للامباكت للفاكتورز دي. تمام. طبعا برضو التريز هنا او الديسيجن تريز طبعا مور يوسفل عن الستاندرد لوجيستيك. زي ما قلنا الستاندرد لوجيستيك ريجريشن هنا انا يعني بريدكت مثلا عندي داتا معينه، عندي فاكتس معينه، تمام، لكن بتبقى الديسيجن تريز دي مور يوسفل بالذات في الرير اوتكم. لما يكون عندي رير اوتكم، لما ما يكونش عندي داتا كتير، لما يكون عندي very high cost hospitalization، ودي بتحصل by group of complex interacting factors. عندي factors مش بس الفاكتورز دي متغيره، لا الفاكتورز دي كمان متشابكه. يعني ايه متشابكه؟ يعني في حاجات بتحصل مع بعض وفي حاجات ما بتحصلش مع بعض، في حاجات بتحصل عكس بعض، في يعني linear regression، في logistic regression، في اكتر من نوع regression معين يعني. تمام. برضو limitation للديسيجن تري دي ان هي اكتر عرضه للاوفر فيتنج. يعني ايه اوفر فيتنج؟ يعني بيحصل مثلا فور اكزامبل ان بيبقى يحصل لها اوفر انتربريتيشن. يعني مثلا فور اكزامبل ساعات كتير بتبقى عندي داتا كتير، الداتا كتير دي ممكن تعمل نويز في الماشين، فبالتالي يحصل لها اوفر انتربريتيشن. تمام. فبالتالي عشان كده بتبقى مهم قوي ان احنا نعمل موضوع التستنج والفاليديشن، ان اوريدي يعني ما فيش نويز في الداتا، ان ما حصلهاش اوفر فيتنج، ان ما حصلش مثلا اوفر انتربريتيشن بشكل معين. فده بيبقى مهم قوي علشان احاول ان انا يعني ابتدي ان انا فعلا انشور ان في credible outcomes عندي. تمام. الديب ليرنينج بقى، الديب ليرنينج هو يعني مختلف شويه. زي ما قلنا هي عباره بيبقى اكتر الجوريزمز، مش بس الجوريزمز دي بتبقى زي لايرز كده، طبقات. يعني ايه طبقات؟ طبقات من الارتفيشال نيورال نتورك. يعني ايه ارتفيشال نيورال نتورك؟ هي بالظبط بتاسمبل مخ الانسان، كأن بالظبط انا بديله داتا معينه. هو اوريدي مخ الانسان يعني طبعا ولله المثل الاعلى طبعا. يعني مخ الانسان بيشتغل ازاي؟ ان فور اكزامبل انت يعني الشخص ده بيتعلم حاجات، بيبقى عنده اكسبيرينس خلاص، فبعد كده لما بيتعرض لحاجه تانية مشابهه زيها بيتصرف تصرف تصرف مشابه، او بيتعلم لا ان هو ما كانش المفروض يتصرف التصرف ده في الموقف ده. فنفس الفكره كده ان يبقى فيه طبعا الجوريزمز معينه ويبقى فيه لايرز معينه. اللايرز دي مبنيه على خبرات متراكمه. ان انا عندي مثلا فور اكزامبل اللاير الاولانيه كان عندي تعليم معين، او كان عندي ايكويشن او الجوريزمز معينه. تاني حاجه تاني لاير عندي معتمده على اللاير الاولانيه، فبالتالي هي لايرز وخبرات متراكمه. عشان كده بنقول دي خبرات متراكمه. يعني ما كانش ينفع ان انا اوصل للخبره دي غير لما اعدي على الخبره بتاعت السنه الاولى والسنه الثانيه، وبعد كده اوصل للخبره بتاعت السنه الثالثه، لان دي بنقول ايه؟ خبرات متراكمه على بعض، فيعني بتمشي بترتيب معين. على قد ما هي كومبلكس طبعا، بس هي اكستريملي فلكسبل. يعني ليه اكستريملي فلكسبل؟ لان انا عن طريقها بقدر ان انا اخلي الابيديميولوجيست عندي يقدر ان هو يحط unlimited number of features او certain characteristics او regression tasks بشكل معين، ونبتدي نشوف تاثير ده على الاوتكم عامل ازاي، او تاثير ده على الديزيز. هل الفاكتورز دي بتاثر بشكل مباشر ولا مش بتاثر؟ فكل ده بيبقى مهم جدا بالنسبه لنا. وبرده في الاخر هوريكم ازاي هي مهمه في الهيلث كير بالذات. يعني هي ليها طبعا ابلكيشنز على صناعات كتير، بس خلينا نتكلم على الابلكيشنز اللي هي خاصه اكتر بالهيلث كير. يعني فهي بالظبط كده زي ما بنقول كده ترانسفورمر او نيرونز معينه. نيرونز بالظبط زي كده يعني لايرز معينه، طبقات دي واخده اكسبيرينس، واخده انستراكشنز، واخده يعني ليرنينجز بشكل معين. الليرنينج ده الطبقه الاولى غير الطبقه الثانيه معتمده على الطبقه الاولى، او اللاير السكند لاير mainly depend on the الاوتبوت بتاعت اللاير الاولانيه. فهي بالشكل ده هي عباره عن مالتيبل لايرز. فبالتالي المالتيبل لايرز دي بتشتغل ازاي؟ اللاير الاولانيه بتدي انبوت، تمام. السكند لاير بتحول الاوتبوت اللي طلع من الفيرست لاير دي تحوله، يعني يبقى بالنسبه لها انبوت. بعد كده تبتدي ان هي تو بروديوس انذر اوتبوت بعد كده another output ده بيبقى transform into input في الثيرد layer، والثيرد layer بتبتدي ان هي تطلع different outcome و different يعني output based على ال previous layers دي. وفي الاخر برضو كل الفاكتورز دي بيبقى ليها weighted combination معين، weighted combination of الانبوت. يعني الانبوتس دي ما بتبقاش زي بعض، لا كل انبوت بيبقى ليه weight معين، weight معين في صناعه القرار او في الديسيجن ميكنج نفسه. يعني الفكره هنا اللي بيفرق ما بين الديب ليرنينج وما بين السنسيتيفيتي اناليسيز اللي احنا بنستخدمها مينلي في الماركوف موديل او في الديسيجن تري، ان هنا في البروبابيلستيك سنسيتيفيتي اناليسيز كنا كانت دايما الديستريبيوشن بتاع الداتا از راندوم، او بيبقى دايما انا ببتدي اخد كده راندوم نمبر اوف iterations بشكل معين، ويعني ما بيكون توتالي راندوم. في الديب ليرنينج لا، مفيش حاجه راندوم، كل حاجه ليها مكانها، كل حاجه ليها الانبوت بتاعها، كل انبوت بيطلع اوتبوت، وكل اوتبوت بيتحول لانبوت في الاخر. فكل ده بيبقى يعني الجوريزمز فيري يعني accurate فيري يعني فعلا بيبقى زي اسمها كده ديب ليرنينج، هي فعلا عامله زي بالظبط هي ديب ليرنينج يعني. تمام، زي ما انتم شايفين كده، زي ما حضراتكم شايفين هتلاقوا هنا different فاكتورز زي الايج، السكس، الدايجنوزس كودز، الانكم، الكو بيمنت، كل ده بيشكل certain factors. الcertain factors دي بتبتدي ان هي interact مع بعض، تمام، وتاثر على الاوتكم بشكل معين. interaction 1 غير interaction 2 غير interaction 3، تمام، بكالكوليشنز معينه، بايكويشنز معينه. فبالتالي دي بتبقى layer 1. layer 1 دي يعني بتبقى هي دي الانبوتس اللي السكند لاير بيعتمد عليها. بيبتدي ان هو الانبوتس دي الهيدن لاير 2 بقى بتكابتشر المور كومبلكس انتراكشنز دي، تمام، وتحولها برضو ل يعني انبوت تدخلها في الاذر لاير، او تبتدي بقى تو بريدكت بقى الهوسبيتاليزيشن ريسك، او فور اكزامبل بقى certain disease hospitalization risk يعني. تمام، فزي ما بنقول كده هي عباره عن نيورال نتورك بتايدنتيفاي كومبلكس انتراكشنز. طبعا زي ما حضراتكم شايفين يعني عندي فاكتورز كتيره، الفاكتورز دي كلها بتنتراكت مع بعض بشكل معين فيري كومبلكس، برضو بترانسفورم الداتا دي into complicated interactions. وبعد كده بيبقى فيه بقى يعني deep learning approach هنا بيقدر يبين لي الاوتكم هيبقى عامل ازاي، هل الفاكتورز دي كلها هتاثر على الاوتكم بشكل مختلف ولا لا. طيب نيجي نتكلم بقى على البوسيبل ابلكيشنز للماشين ليرنينج. اول حاجه طبعا مهم قوي ان انا تو استيميت التريتمنت ايفكت. انا ليه اساسا بعمل ماركوف موديل وبريدكتيف موديلنج وديسيجن اناليسيز؟ علشان انا عايزه استيميت التريتمنت ايفكت على اللونج ران، تمام. فبالتالي انا بستخدم ماركوف موديلنج كل ده لو انا عندي داتا ثابته. طب لو انا عندي داتا متغيره، across time، وكمان التغير ده انا برضو مش عارفاه، ستيل برضو يعني بالنسبه لي not identified yet. فلما يكون عندي heterogeneous treatment effects، لما يكون عندي مثلا كمان for example ان البيشنتس عندها heterogeneous treatment effect، البيشنت ده مش زي البيشنت التاني، مش زي البيشنت الرابع، طبعا بيبقى فيه سامبل، طبعا بيبقى فيه سامبل سايز بشكل معين، طبعا بيبقى فيه مين، بيبقى فيه افريج للتريتمنت ايفكت ده. بس لما يكون في عندي different heterogeneous treatment effect، هنا بقى لازم استخدم الماشين ليرنينج. ليه؟ لان الماشين ليرنينج بيقدر ان هي تكنولوجي عاليه جدا، تقدر ان هي يعني تبين لي حاجات انا مش هقدر ان انا ابريدكتد لوحدي يعني. تمام، بالظبط يا دكاتره، زي ما احنا بنيجي نتكلم مع حد في التليفون وتاني يوم نلاقيه نزل عندنا على الفيسبوك people you may know. هي دي ايه؟ دي الجوريزمز بالظبط. هو الفيسبوك شغال بالماشين ليرنينج نفس الفكره. ان فور اكزامبل مثلا انت اتكلمت على سمارت فون بتاعك، انت اتكلمت 10 دقائق ربع ساعه مع الشخص ده، تاني يوم بتلاقيه عندك على الفيسبوك، لان خلاص اوريدي الداتا كلها متوصله ببعض. فهي اوريدي يعني هي دي فكره الماشين ليرنينج، ان انا عندي داتا صغيره قد كده، عندي يعني فيري سمول داتا، اقدر بالفيري سمول داتا دي ابريدكت اوتكم معين او بريدكت حاجه معينه، ان انت ممكن تبقى عارف الشخص ده، فحاول ان انت تكونكت على الفيسبوك. فنفس الفكره كده بالنسبه للديزيزز او بالنسبه للهيلث كير. انا مثلا فور اكزامبل عندي heterogeneous treatment effect، فببتدي بقى اشوف الامباكت بتاع الهيتروجينس تريتمنت ايفكت ده على الديزيز اوتكم او على الاوتكم بتاع البيشنتس نفسه. طبعا ده بيدي مور ريجوريوس ميثودز، يعني طبعا بيدي مور ريجوريوس طبعا ريزلتس. بيبقى عندي طبعا يعني غير بقى لما اجي مثلا مجرد اتشينج جاست وان فاكتور، اتشينج مثلا تو فاكتورز او كده، لا هو مين اللي انا هنا ببتدي ان انا يعني اكسبلور بقى different heterogeneous treatment effect عن طريق بقى طبعا الداتا اللي عندي، وعن طريق ان انا ببروسيس الداتا بشكل معين، فبالتالي بيطلع لي different treatment effects، ما بيطلعليش median treatment effect مثلا فور اكزامبل، لا بيطلع لي different treatment effects. هنا برضو كاكزامبل ليها في الاستيميتنج تريتمنت افكت اللانست مثلا فور اكزامبل ده يعني هتلاقوا مثلا هو لسه ناشر دراسه قريب قوي بيتارجت الويت لوس انترفنشنز تو ريديوس الكارديوفاسكولار كومبليكيشنز بتاعت تايب 2 دايابيتس ميليتس. تمام، دي كانت بيزد على كلينيكال ترايل، يعني دي كانت ستادي اتعملت ماشين ليرنينج، استخدموا فيها الماشين ليرنينج بيزد بوست هوك. يعني ايه بوست هوك؟ يعني بعد ما الدراسه خلصت، خدوا الداتا بعد ما الدراسه خلصت خلاص تمام، وابتدوا يعملوها اناليسيز بشكل معين ويانلايز فيها الهيتروجينس تريتمنت ايفكت علشان يقدروا يوصلوا ويشوفوا مين احسن ويت لوس انترفنشن، مين هنقدر ان احنا نادوبت الويت لوس انترفنشن اللي فعلا هيقدر ان هو يحسن لي الكومبليكيشنز بتاعت التايب 2 دايابيتس، خصوصا لو بتكلم على الكارديوفاسكولار. فهنا الدراسه كانت بتكونكلود ايه؟ هنا مين الدراسه كانت بتكونكلود ان ستيل البيشنتس with moderately or poor control diabetes او البيشنتس with well controlled diabetes برضو كل دول كانوا يعني avoided the cardiovascular events from behavior intervention. يبقى كان احسن حاجه بيقدر ان هو يقدم treatment effect اعلى هي behavioral intervention weight loss program، يعني ده اللي يقدر ان هو يعمل لي avoiding للكارديو ايفنتس بشكل اعلى. طيب برضو الايمج ريكوجنيشن، الايمج ريكوجنيشن دي كان في من كام يوم كده اعلان على لينكد ان حاجه اسمها البيل كام. ايه هي بقى البيل كام دي؟ دي قرص بياخدوا البيشنت لما يكون مثلا فور اكزامبل عايزين ياخدوا عينه معينه، عايزين ياخدوا بايوبسي من مثلا الريكتم، بايوبسي من الكولن. فطبعا علشان اقدر اعمل بايوبسي واقدر اطلع عينه لازم اعمل انفيزيف بروسيدير، لازم يكون عندي سيرجري، لازم يكون في سيرجري تتعمل، لازم يكون في انفيزيف بروسيديرز تتعمل علشان اقدر ان انا يعني انفستيجيت اوريدي القولون واقدر ان انا انفستيجيت الريكتم بشكل معين. يعني دلوقتي البيل كام دي هو قرص انت يعني جاست بتبلعه، بيبتدي بقى ان هو يدخل جوه الجسم ويقعد يصور حاجات ويبعتها على الكمبيوتر بقى، طبعا بيبقى متوصل بشكل معين، بيقدر يصور بالظبط الريكتم من جوه عامل ازاي، فور اكزامبل في التهابات، في تيومر، في حاجات معينه، فكل ده يبتدي يبعت صور كانه بالظبط انا بانفستيجيت او بعمل ايمج ريكوجنيشن جوه جسم البني ادم. فده اوريدي دلوقتي خلاص، ده يعني المفروض دي يعني بيل كام دي اوريدي يعني لونشد باي ميدترونيك يعني. ففي تكنولوجيز رهيبه، يعني تكنولوجيز مينلي مبنيه على فكره فعلا الماشين ليرنينج نفسها يعني. وعندي طبعا انترناشونال كومبيتيتورز كتيره واورجنايزيشنز كانت بتديفوت بس يعني كل الافورتس بتاعتها تو الايمج اناليتكس، لدرجه ان في مؤتمر اسمه ايمج كلاف ده عباره عن كامبينز معينه او سلسله مؤتمرات بشكل معين عشان يبتدوا يشوفوا الابديتس اللي موجوده اوريدي في الماركت في الساينس ده او في العلم ده. تمام. وطبعا يعني بتبقى طبعا الساينس ده بيبقى مهم جدا جدا مينلي علشان كمان في الاستخدام بتاع الابلكيشنز في الابيديميولوجي. يعني اي ابيديميولوجيست هو عايز يعرف قد ايه عندي لان كانسر، قد ايه عندي بريست كانسر، فلازم يبقى عارف كل الداتا دي عشان يقدر يبروسيس بالشكل الصح. برضو من ضمن الحاجات اللي بتستخدم فيها الماشين ليرنينج البريسيشن هيلث ايكونومكس اوتكمز ريسيرش. البريسيشن هيلث اوتكمز ايكونوميك هيلث اوتكمز هيلث ايكونومكس اوتكمز ريسيرش ده انا ببتدي ان انا اقسم التارجت بوبيوليشن اللي عندي انتو كوهورتس، بقسمهم انتو كوهورتس، كل كوهورت بشكل معين ممكن يبقى ليه فينوتايب مختلف، ممكن يبقى ليه سيمبتومز مختلفه.
فينوتايب بشكل مختلف. فبالتالي ده بسميه precision health economics and outcomes research، لان انا هنا بانتجريت الايكونوميك والكلينيكال فاليو اسسمنت مع بعض عشان اقدر ان انا اديسكفر اي distinct clinical او health care utilization phenotypes معينه ممكن انها تحصل يعني. تمام. من اول بقى الانيشاليزيشن بتاعه التري نفسها او بتاعه الديب ليرنينج ده، بعد كده ببتدي ادخل الكانديديت بريدكتورز اللي ممكن تغير لي الايفكت بتاع الديزيز نفسه او بتاع الدواء. بعد كده بقدر بعمل سبليتنج رولز، بيبقى بقى في البي فاليو ثريشولد ده يعني بيبقى في عندي مينيمم نمبر معين اوف الاوبزرفيشنز. تمام. وعندي طبعا ستوبنج رول برضو، يعني عندي سبليتنج رول وعندي ستوبنج رول لو في حاله مثلا التيرمينال نيد، او في حاله مثلا ان انا عندي الماكسيمم نمبر اوف الثري لايرز، خلاص مش هحتاج 3 لايرز ثانيه يعني. تمام. طيب ايه الصناعات او ايه الاندستريز اللي فعلا امباكتد باي الارتفيشال انتليجنس ريفولوشن؟ طبعا عندنا حاجات كتير قوي زي الهيلث كير، زي الصناعه، مانيفاكتشرنج، الترانسبورتيشن. دلوقتي عن طريق الترانسبورتيشن انت خلاص بتدخل بابلكيشن معين يقدر يعرف مكانك بالظبط. فكل الحاجات دي تطبيقات artificial intelligence يعني. education، فكره الزوم ميتينجز ان احنا نبقى مع بعض كلنا في كذا دوله في وقت واحد، كل دي تكنولوجي، كل دي مبنيه على فكره ان انا عندي تكنولوجيز جديده يعني. وطبعا الاي تي، طبعا البيزنس انتليجنس، قد ايه مثلا الشركات الكبيره دلوقتي عايزه تو انالايز البيزنس بتاعها، فعندها بلنتي اوف داتا، عندها داتا كتيره جدا، فايتس فيري امبورتنت تو انالايز ذيس بيج داتا علشان تو جايد ذم في تيكينج ديسيجنز. عايزين يانالايز البيزنس بتاعهم، مهم قوي يعني طبعا في حاجه زي كده. السبلاي تشين مانجمنت طبعا علشان يبتدي يبريدكت السبلاي في certain hospitals، فبالتالي لو حاجه نقصت يقدر ان هو يعوضها ويقدر ان هو يمانج يعني. تمام. والكونستراكشن طبعا والريتيل والسايبر سيكيورتي، كل دي تطبيقات يعني اوريدي بتستخدم الارتفيشال انتليجنس في حاجه زي كده. فيعني اتس فيري امبورتنت. عايزه اقول لكم كمان ان الماشين ليرنينج مش بس يعني فكره ان الماشين ليرنينج ده علم جديد ولسه ما فيش عليه شغلانات في مصر او كده،